Hello, everyone, and welcome to our 26th lecture in our course on brain and behavior. And this will be sort of a standalone lecture on the topic of schizophrenia. So psychological disorders are various. There are many of them. You could spend an entire course talking about psychological disorders, and we just don't have time for that. So what we're going to do is pick a particular psychological disorder and relate it to the brain and behavior. And that can serve as sort of a template for our thinking moving forward, how we think of psychological disorders. We'll do a little bit of history here today, but mainly we'll talk about what schizophrenia is and how it relates to the brain and what we know. And as we'll see, we don't know everything. We know a bit, but we don't know it all. And so there's still a lot to learn about this disorder in particular. But we know some, and so that's why I've picked it here. So we're talking about schizophrenia, and we'll begin with the symptoms. What does one experience if one has schizophrenia? We'll talk about the risk factors. So what environmental and genetic traits and experiences might one have that increase the risk of developing schizophrenia? And some of these are very far apart in terms of time from the onset of symptoms. So we'll see that genetics, prenatal development, events at birth, can all contribute to later development of schizophrenia, even though the symptoms won't show up for 20 years. So it's a very interesting phenomena how far apart what we think the causes are from the actual onset of symptoms. And when it comes to causes, we'll see that these risk factors combine in an interesting way. That, like most disorders, it's not entirely genetic, but it's not entirely environmental. But it's really the combination of the two, and we'll see how that plays out. And then at the end, we'll talk about treatment. What can one do for the symptoms of schizophrenia? There is no cure for schizophrenia. There's only treatment for the symptoms right now. And so we'll see what some of those treatments are, what the pros and cons are. So we'll see that schizophrenia, in terms of symptoms, some symptoms are gains, not in the sense of something you would want, but behaviors and experiences that people don't typically have, but those with schizophrenia do. Other symptoms involve losses, the loss of emotional expression, for example. So things that typical individuals have that individuals with schizophrenia do not. And we'll see that combination of genetic and environmental factors leading to the onset of symptoms, usually in late adolescence, early adulthood. And when we talk about treatments, and this is true again for many psychological disorders, that's another reason why I've picked this as an example, we have some treatments for the psychological disorder, even though we don't completely understand what causes the disorder, how the disorder works. So, like many drugs, the first drugs for treating schizophrenia were kind of discovered by accident. But it was discovered by accident that it worked on at least some of the symptoms of the disorder. And so similar drugs were developed that had fewer side effects or affected more of the symptoms. And so even though we don't understand the root cause of schizophrenia, we still have medications that can treat it. So a little history of psychiatric disorders in general, but schizophrenia is certainly a good example here. For centuries, probably millennia, schizophrenia and other psychiatric disorders, things like epilepsy, for example, which obviously has a more biological component that we're aware of, were treated as sort of supernatural. So here I have a picture of the moon, and we know that the adjective form of the moon is a lunar, and we have words like lunatic that describe just a generic crazy person, which is not very scientific, but that's how people use the word lunatic. And that word comes from the fact that people used to think that the moon affected people's mental states. Other supernatural causes like demons or ghosts or spirits or whatever you want to call them, possessing people, and that's what caused seizures and epilepsy, or that's what caused the delusions and hallucinations and bizarre behaviors in schizophrenia. And so that's sort of the way it was for hundreds of years, and treatment for mental illness was certainly not effective, but was very brutal. People would be burned or flogged or doused in cold water, bled, subjected to all sorts of horrible treatments that were supposed to treat the disorder, but of course didn't. And so a lot of it was tied up with superstition and folklore, and not much progress was made until around the 18th century. The idea of institutionalization. Somebody put forth the idea that rather than subject the mentally ill to treatments like those that had been used, that special facilities should be dedicated to them. Now, again, mental disorders could not be really treated or cured at this time. This is really just a place to house people with psychiatric disorders, not so much to treat them, but to keep them from being harmed by other members of society, to keep them from harming other members of society, even though generally the rate of aggression among people with psychiatric disorders is pretty low. But the idea of a mental institution as not so much a prison, although effectively that's what these often were, but as a special facility just for the mentally ill. And the conditions in early mental institutions were not good. They were not very clean. They were not very good in terms of providing food and shelter and clothing to the patients. So this is a picture not from your book, but if you've ever heard the term bedlam, meaning chaos, that derives from a mental institution called Bedlam Asylum. And that's what this woodcut is a picture of. And you'll notice also that there are two well-dressed individuals in the background. Those are members of the public that have paid to come in and basically watch the patients for entertainment. So that's how institutions were for a long time. The ethics got a little bit better. Our method of treatment got a little bit better. But that's sort of the way things were until the middle of the 20th century, when the first psychiatric medications were developed. Also during the 20th century was sort of another dark chapter in terms of treatment, the development of what was called the frontal lobotomy, where the frontal lobe was literally severed from the rest of the brain. It was a quick procedure. It was relatively simple. A metal rod was basically inserted through the nose into the brain cavity, and the frontal lobe was severed. And it was hailed at first as a miracle cure for schizophrenia, that those that exhibited disruptive, perhaps even violent behaviors before, no longer did so after a frontal lobotomy. And that was true, but they also didn't do anything else. Many of them became catatonic, non-responsive, they lost their personalities. So there was an enormous downside, and frontal lobotomies are not done anymore, thankfully. So this is an image of Rosemary Kennedy, a member of the famous Kennedy family. And whether she ever actually had schizophrenia is controversial. In fact, she probably didn't. But she was subjected to a frontal lobotomy and lived out the remaining decades of her life. She got the procedure done when she was in her early 20s, had a frontal lobotomy and lived for decades afterwards, but was no longer capable of taking care of herself. She was institutionalized. So that is sort of up through the 20th century. As we'll see, drugs were developed that alleviated at least some of the symptoms and made institutionalization less necessary in most cases. Again, talking about psychiatric disorders in general, these have a huge impact. Many people, just in society at large, think of psychiatric disorders as a problem that someone else has. They're very common, and they have a huge impact. It's not something that someone else has and only affects them. It affects all of us. And estimates range as high as half of the U.S. population will have a diagnosable psychiatric disorder at some point in their lives. Obviously not necessarily schizophrenia, but things like depression, anxiety disorders, personality disorders are all included here. And who is likely to get a disorder? It can be biased by sex, age, ethnicity. So mental disorders at large tend to be slightly more common in women than in men, particularly mood disorders, whereas substance use disorder is far more common in men. Schizophrenia is also more common in men by a factor of about 50%. It's about 50% more common in men than in women. And this is a diagram not from your book, but the age of onset is also a little bit younger for men. So men tend to get it, develop schizophrenia in their late teens, early 20s. Women tend to develop a little bit later, maybe in their mid 20s. This diagram makes it look like it's more common in women than in men. It's actually not. So don't let that dissuade you from the fact that it's more common in men than in women. This is just to show you the age of onset. It's a little bit earlier in men. So what is it? Well, it's a psychiatric disorder. It's a psychopathology. And it has an enormous impact. So worldwide, estimates are usually around 1%, that 1 in every 100 people suffers from schizophrenia. That's a lot of people. I mean, there are certainly a lot of people in the world, call it 7 billion is the approximate number, but think about 1% of 7 billion. So we're talking about 70 million people. And that's a large number of people with this disorder. So it's certainly worth considering from a patient perspective, also from a patient perspective and a social perspective. Around 5% of individuals with schizophrenia end up committing suicide. That takes an enormous toll, obviously, on the person themselves, but the people around them, on society at large. And notice that is the completion of suicide. That is not just attempting suicide. That number is much higher. It accounts for a large proportion of hospitalization because it's not curable, because its symptoms are severe. And so estimates range up to about a third of hospitalizations are for schizophrenia. Because, again, it can't be cured, it can only be treated, and one of the common behaviors is that a person will start medication, their symptoms will be alleviated, but the medication also has side effects, or the person thinks they're cured until they stop taking the medication, and so it recurs. Also, a large proportion of the homeless population, again, about a third, we think suffers from schizophrenia. So because of how devastating this disorder is in terms of being able to take care of oneself, a large portion of that group end up homeless on the street. And this is the Diagnostic and Statistical Manual for Mental Disorders. It's in its 5th edition, so it's called the DSM-5. There used to be subtypes of schizophrenia that were part of this manual, things like paranoid or hebephrenic. And the idea for those was that certain symptoms sort of went together in groups, and that this constellation of symptoms was one type of schizophrenia, and this other constellation of symptoms was a different kind of schizophrenia. Statistically, that seems not to be the case, that there aren't sort of clusters of symptoms, that anyone with schizophrenia could have any of the symptoms on the list. So the subtypes idea hasn't proven useful, so it's no longer there in the DSM-5. What are the symptoms? Well, the first group are what we call positive symptoms. And these symptoms are positive not in the sense of being beneficial, but in the sense of positive numbers, things that have been gained or added. The most famous is probably hallucinations. And these are almost always in the form of auditory hallucinations. The person will hear voices that aren't there, voices that tell them to do things, or voices that comment on them or criticize them. And so this is a common positive symptom. Another common symptom are delusions. So these are beliefs that are irrational, but don't go away when the person is presented with refuting evidence. The most common form of delusion is the paranoid delusion, the belief that someone is out to harm them, or that someone is listening in on their thoughts or their conversations. And even when you demonstrate how unlikely that is or how impossible that is, the delusion persists. And a little word of caution here, you have to take culture into account. If you think about many of the superstitions in our culture, those are irrational. Those don't stand up to scrutiny, but they don't count as delusions because they're culturally based. So if you believe that breaking a mirror causes bad luck, that wouldn't count as a delusion because it's a common cultural belief. Whereas believing that the government is listening to your thoughts through the fillings in your teeth, that would be a delusion, because that's not a common cultural belief. Disorganized thinking, this usually presents itself through speech. So the person will engage in tangential thinking. They lose their train of thought. And they'll use a word in one sentence, and the next sentence they'll use a word that rhymes with the first word, even though the sentence itself isn't related semantically in terms of content to the first one. And so they'll exhibit this sort of rhyming speech, or just sort of random train of thought sort of thinking. That stream of consciousness style of conversation. And we've probably all exhibited a lack of organization in our speech at some point, but this is consistent and severe. So this is where the next sentence has nothing to do with the previous one. And what are called bizarre behaviors, which sounds sort of vague, and could be used as sort of a catch-all. But what this often is repetitive movements or unusual posture. So it's not complex behaviors usually. It's usually what the person does with their body. And then there are negative symptoms, things that are lost. So these are, again, negative in the sense of negative numbers. So one thing is that people often withdraw socially. They lose social contact. They lose interest in forming social relationships. And this can sort of be a vicious cycle because without a social network, no one is around to monitor symptoms, to check on the welfare of the person, and so this can often make things worse. Another common symptom is what's called flat affect. And this is where the person exhibits a lack of emotion and a lack of facial expression, even if they're talking about a very emotional topic. As we just saw on the previous slide, paranoid delusions are a common symptom. And these are usually beliefs that would be very upsetting to the typical person. The belief that someone is out to harm you. And yet, the sufferer of schizophrenia will describe this with flat affect without responding much to it emotionally. Also, anhedonia, the loss of the ability to feel pleasure. And we see in this word, Hedon, so it's the same root as a hedonist or hedonism, the pursuit of pleasure. So anhedonia is the loss of pleasure. There's also alogia, which is what's often called poverty of speech. The person won't initiate speech as much as the typical person. And again, in the previous slide, we saw disorganized speech as a symptom. And that means that when speech occurs, it is disorganized. They exhibit rhyming associations or tangential thinking. But at the same time, they also tend not to speak as much. And then finally, there are cognitive symptoms, difficulties processing information. There's a loss of memory, so memory deficits, particularly verbal memory, memory for words. Difficulty maintaining attention, being easily distracted. Social perception, so we just saw social withdrawal as a negative symptom. And part of the reason for that may be that individuals with schizophrenia have difficulty with social perception, understanding what other people are thinking or feeling, and trying to guess what someone's going to do next, trying to guess how they will react to the person's behavior. And so because of that difficulty, because of negative events that may result from impaired social perception, that may contribute to the person's social withdrawal. They may no longer be comfortable in social situations. At a more basic psychological level, individuals with schizophrenia have trouble with inhibition, restraining actions, particularly habitual actions. So this is what's called a go, no-go task. And as you see here, the letters in blue, the person is instructed to hit a button anytime these letters come up. Well, that's pretty easy. So the letter comes up, you hit a button. Letter comes up, you hit a button. If in this case it's an X, if an X comes up, you're supposed to not hit the button. The vast majority of the time, you press the button after the letter comes up. It becomes habitual. Letter, button press, letter, button press. After a while, one of these X's comes up, and you're supposed to not press the button. And this is a study of individuals that are control individuals, that is, don't have schizophrenia. They're shown in gray here on the left side of these bar graphs. And then the patients with schizophrenia are shown on the right. And what this shows is the number of errors, the accuracy of these individuals. And both the control subjects and the patients have no trouble pressing the button when one of the normal letters comes up, one of those blue ones on the left. So their reaction time is fine, their accuracy is fine. But when it's one of the X's, when it's the letter they're not supposed to press afterwards, the control individuals make some mistakes, but the individuals with schizophrenia make far more mistakes, significantly more mistakes. So what this means is that they have trouble inhibiting that habitual response of button pressing. They have trouble controlling that impulse. Also, they have trouble controlling eye movements. And this is obviously a very basic response, where your eyes are pointed. So if an object is moving smoothly back and forth, on the top here we see a control individual's eye movements. They're very smooth, back and forth, this wave up and down. An individual with schizophrenia, the movements are not smooth. They jerk around. So the eyes, even though the target is moving smoothly, the eyes do not follow smoothly. They'll lag behind and then skip ahead, lag behind and then skip ahead. So they have trouble with basically target-based eye movements. So these are all cognitive symptoms of schizophrenia. And here we're going to see a video where the individual is being interviewed and listen to what the person says, but also how they're behaving. We're going to see some of these symptoms of schizophrenia.
Hey, what brought you into the hospital?
I turned myself in on a 5150 because I felt like killing myself.
Okay, so you came here voluntarily.
So I could stop from killing myself.
And what was going on that you felt like killing yourself?
It was 3 o'clock in the morning. I couldn't sleep. All the same thoughts kept racing through my mind over and over and over again. I just wanted them to stop. Period. Then I thought, well, if I kill myself, I'll stop thinking. And I thought, well, that isn't too good of an idea either, because you've got friends and people around you who love you. So I stopped that thought. And I said, well, who am I going to call? And I called up Ghostbusters. I mean, no, that came out wrong. It's a joke. I didn't call Ghostbusters. I called up Crisis Intervention Center and talked to them on the phone.
Have you ever made any suicide attempts?
Oh, yeah, I have. A couple of them when I was 19.
Okay. Are you usually able to ask for help when you start feeling like that?
No, I was never able to ask for help before.
That's all the questions I have for right now.
Can I go back in now? Yeah, I'm getting very uncomfortable out here. I think somebody might be trying to shoot me. Someone might be trying to kill me.
Okay, so we saw many of the symptoms that we were just talking about in the last few slides. So we saw, obviously, a paranoid delusion. This patient thinks that someone is trying to kill him, trying to harm him. We saw some flat affect, not a lot of emotional response. We saw suicidal ideation, as we saw at the beginning today. There's a very high suicide rate among those with schizophrenia. And what may not have been as obvious is that disorganized speech. You'll notice he said, okay, well, I was thinking about killing myself, and so who did I call? I called Ghostbusters. No, wait, I didn't mean that. I didn't call Ghostbusters. I called the hotline. So who you're going to call Ghostbusters is a lyric from the theme song for the movie Ghostbusters, which you may not have heard before, but that's one of the lyrics, and it was, especially at the time this video was taken, that was a well-known song. And so when he said, who did I call, he went on a tangent. He echoed that song lyric instead of following through on his train of thought and relating the story. So that's some of that disorganized speech. So what causes one to have schizophrenia? Well, certainly there's a genetic component. So if you look here at this graph from your book, you'll see that the more related you are to a person with schizophrenia, the more likely it is that you'll develop schizophrenia yourself. But it's not simply the matter of inheriting a single gene. Many traits come down to a single gene, but schizophrenia does not. And so there are multiple genes involved, which makes it much more complicated when it comes to predicting it. What we do know is it has what we call a concordance of about 50%. If you have an identical twin with schizophrenia, your risk is about 50%. So it's much higher than the average population, which is 1%. So there is clearly a big genetic component, but there's also a non-genetic component. It's not 100%, it's 50%. So what are some of those environmental risk factors, those non-genetic risks? Well, one interesting one is that an urban environment seems to matter. So this is a graph from your book. As a baseline, they measured how frequent schizophrenia was for individuals that lived in a rural area, and then compared it to individuals that moved to a small city or a big city. So this line in the middle is the small city. Their risk goes up. It's up by about 50%, and it's greater for those that move to a city earlier in their lives. More exposure. The risk goes up, doubles, for people who move to a big city. And again, that risk is bigger the earlier you move. A birth month, also a risk factor. So people that are born in the late winter, early spring months are at higher risk for schizophrenia. And we think that's because the gestational window for those births means that the mothers, while pregnant, during a particular window in time at which this is a risk, get diseases like the flu or rubella. And so these seem to be, not all illnesses, but these particular illnesses seem to place the fetus as it's developing at a higher risk. The timing matters. It's not the entire pregnancy this is a risk, but there's a certain window, which is why births in late winter, early spring are at a higher risk, because they're preceded by parts of the year when flu and rubella are more common. So this combination of genetic and environmental risk factors has led to what's called the neurodevelopmental hypothesis. And this is what's also known as a diathesis stress model, if you've heard that term before. On the right here, we see the Genane quadruplets. And these are identical quadruplets that all developed some form of schizophrenia, some more severe than others. One had to be institutionalized for pretty much her entire life. Two others were able to manage their symptoms and had lives outside of an institution. So the severity mattered, or varied, but what was clear was that because they shared not only their genes, but also their environment, that both of these have a big role to play. The odds of 4 unrelated individuals all developing schizophrenia are very low. They're 0.01 to the 4th power. However, this happened. These quadruplets all developed schizophrenia. Because they shared an environment, because they shared their genes, their risk was much higher. They had a family history of mental illness. They had an abusive environment growing up. So a lot of stressors. And so this points out that these things interact. There's an interaction between genetic factors and stress. Having a lot of both puts one at very high risk for schizophrenia. Having a lot of one but not the other, the risk is lower. So the idea here is that without stressors, even with a few genetic risk factors, the person can exhibit typical development and go on to having mental health. However, stressors, particularly early stressors, at birth, during young childhood, a stressor introduced, if it's severe enough or if there are enough stressors, can lead to atypical development and mental illness in the form of schizophrenia. So that's the idea. The person is obviously born with their genes, certain genetic risk factors, and then from then on, it's what does the environment have in store for them? Is it a nurturing environment with relatively few stressors? Or is it a very stressful environment characterized by things like abuse or malnutrition? So how do we diagnose this? It's not all or none. That is to say that people are obviously neurotypical without schizophrenia. People sometimes have schizophrenia. That's diagnosable. But there's also a middle ground. So we see in this diagram from your book, there's what's called schizotypy and schizophrenia spectrum disorders, which are less severe. Fewer symptoms, less severe versions of those symptoms, displayed less frequently. And so there is some middle ground here. So we're not going to go into the details here, but schizotypy is like schizophrenia, but again, not as severe. Similarly, spectrum disorders are even less severe than schizotypy. And again, the person may have fewer symptoms or may not exhibit those symptoms very often. In fact, they could just exhibit them a handful of times. And that's what makes the difference in diagnosis. So on this graph here on the right, we see this interaction between genetic factors and environmental factors. On the x-axis are genetic factors. The more genetic factors one has, the fewer environmental factors it takes to trigger schizophrenia. Conversely, one might have only a few genetic factors, but if one is raised in a very stressful environment, one could go on to develop schizophrenia. Moderate amounts of both can lead to schizophrenia or schizotypy or a spectrum disorder. So it's really the combination of the number of genes favoring schizophrenia and the number of environmental stressors, particularly early stressors in life. This graph is sort of an indicator of how, certainly if you have a lot of both, your risk is very high. If you have a few of one and a lot of the other, your risk can still be pretty high. These things combine. So specifically, the diagnosis of full schizophrenia requires two of the following symptoms for at least a month. Hallucinations, delusions, and disorganized thought, behavior, or speech. In addition to a negative symptom. So the first three are all positive symptoms. And you have to have at least one positive symptom to qualify for a diagnosis of schizophrenia. You can also have a negative symptom. You could have two positive symptoms and no negative symptoms and still qualify. But you could have one of the positives and a negative and qualify for a diagnosis. So not everyone has the same symptoms. In fact, you could have two people with totally different symptoms that still were diagnosed as having schizophrenia. Another part of this diagnosis is that it has to impair social function, occupational function, family function for a period of at least 6 months. So there has to be some duration. And this may seem confusing. How can you have the same disorder but different symptoms? But lots of psychological disorders are done this way. Things like depression or anxiety disorders. You might have two people with the disorder that don't exhibit the same symptoms. And the idea is that the symptoms tend to occur together. And so there's no meaningful distinction in saying, oh, these symptoms are part of the disorder and these symptoms are not. You could have a collection of these and qualify, and that they seem to result from a common basis. So what's happening in the brain? This is our course about brain and behavior. We've talked about behavior and some of the symptoms of schizophrenia. What is happening in the brain? Well, there are some structural differences. One of the most noticeable is the enlargement of the ventricles, particularly the lateral ventricles. So on the left here, we see an individual, a member of a pair of twins that doesn't have schizophrenia. The twin on the right does. And we see those ventricles are much bigger, those fluid-filled cavities in the brain. And this is not because there's increased fluid pressure. The person isn't producing more cerebrospinal fluid, and so those ventricles aren't inflating in any sense. It's because the surrounding tissue is shrunk. And so that's why the ventricles get bigger. More evidence of loss of neurons, or at least neural tissue, is the loss of gray matter during adolescence. So on the left here, we see a healthy adolescent. On the right, we see an adolescent with schizophrenia, and we see those red portions of this image, which indicate where tissue is being lost. So the frontal lobes, the parietal lobes, even the temporal lobes, generally most of the brain. but we're seeing loss of cortex. One thing that may be contributing to that loss is the loss of dendritic spines. So moving down to the very small scale. The top row here, we see a control individual, and we see a many dendritic spines budding off of these dendrites. On the bottom, we see individuals with schizophrenia, not nearly as many dendritic spines. So dendritic spines obviously connect to neighboring neurons. So this means that the individual with schizophrenia has fewer synapses and has less overall volume. Dendritic spines take up space. And so if you have fewer of those, you're going to have less volume. Interestingly, the neurons also appear to be disorganized. So here we see a slice of hippocampus from a typical individual. And if you look at this picture, you see that the neurons, the cell bodies at least, look like little triangles. And they're all pointed up. The point of the triangle goes up. And they're all sort of organized, kind of pointing in the same direction. This is an individual with schizophrenia. Those triangles are sort of pointing in every direction. There's not an overall organization to them. So in addition to the loss of neural tissue in dendritic spines in particular, there's also a loss of organization of neurons. So those are all structural differences. What about functional differences? So one commonly noted difference is what's called hypofrontality, or the hypofrontality hypothesis. The idea that individuals with schizophrenia have less activity in their frontal lobes in particular. So if you measure frontal lobe activity in control individuals and individuals with schizophrenia, there's a little bit less activity in the frontal lobe in those with schizophrenia. If you give them a complicated task to do, something that's very hard, the individuals that are in the control group exhibit more activity in their frontal lobes. There's even less activity in those with schizophrenia. So there's a bigger difference, especially when the person is engaged in a difficult task. And that may have something to say about cognitive capacity in schizophrenia. So what does the frontal lobe do? Well, we know one thing it does is executive function, which we've already talked about in a previous lecture. So the ability to inhibit actions, to keep a task in mind, to stay organized, to keep context in mind, to follow rules. These are all part of executive function, and these are the sorts of things that individuals with schizophrenia have trouble with. We've already seen that they have trouble inhibiting habitual actions. They have trouble keeping rules in mind. They have trouble controlling attention. Also, the frontal lobe is involved in working memory. That portion of your memory where you are literally keeping something in mind very actively. You might even be rehearsing it to yourself, saying it over and over to yourself. An interesting experiment looked at brain activity in the frontal lobe. And before we start to think that it's the entire frontal lobe, it's sort of undifferentiated decrease in activity, there's this experiment. You can look at two very nearby regions in the frontal lobe. In one of the regions, when you give someone a task that involves their memory, they have to keep a sequence of letters or numbers in mind and keep on putting away the oldest one and bringing in a new piece of information, so the numbers and letters are always changing. That's what we call a working memory load. It takes some thinking. It takes a lot of working memory to do well. And in one portion of frontal cortex, there's no difference in performance. However, in what's called the dorsolateral prefrontal cortex, which we know is involved in working memory as well as following rules, we see a big difference in performance and a difference in brain activity in this region. So it's not the entire frontal lobe that seems to be different. It's selected portions, and those portions seem to have a lot to do with working memory and executive function. So how do we treat schizophrenia? As we've already seen, we can't cure it. We can treat the symptoms. And this is done with what are called antipsychotic drugs. This refers to psychosis, the state of mind of a person with schizophrenia, a break from reality, bizarre beliefs, a depersonalization, a sense of distance from oneself. That's what psychosis is. And so antipsychotic drugs are intended to combat psychosis. And antipsychotics tend to be better about treating the positive symptoms than the negative ones. And in some sense, that's okay, because the positive symptoms tend to be more disruptive. The loss of the ability to feel pleasure, flat affect. These are inconvenient, but they are not as disruptive as auditory hallucinations and delusions and disorganized speech are. So while it would be wonderful to have a drug that treats all of it, the antipsychotics tend to treat the positive symptoms a bit better than the negative ones. And what antipsychotic drugs tend to do, and what we call the typical antipsychotics, more on that in a second here, what they tend to do is they tend to be dopamine antagonists. So if you measure how much is needed to have an effect for these antipsychotic drugs and how well they bind to dopamine receptors, there is a very tight relationship. Also, individuals that take a large number of stimulants, amphetamines in particular, if they take a very high dose, they tend to exhibit some of the symptoms of schizophrenia. They'll start to hear auditory hallucinations. They'll start to exhibit paranoid delusions. And it takes a very high dosage to do that, but this is what's called amphetamine psychosis. There's that word again. And one thing amphetamines do is boost dopamine levels. And so this led to the idea, the dopamine hypothesis, that schizophrenia is the result of too much dopamine, or at least the overactivation of dopamine receptors. As we know now, that's overly simplistic. There are many regions of the brain that exhibit too much dopaminergic activity, and that's correlated with symptoms of schizophrenia. There are other regions, though, that exhibit too little dopamine activity. So it's not simple. It's not as simple, unfortunately, as too much dopamine equals schizophrenia. But there are some pieces of evidence in support of the dopamine hypothesis. How the drugs work, the fact that amphetamines and other stimulants increase dopamine and can cause symptoms of schizophrenia, those are in favor of it. What's perhaps a strike against the dopamine hypothesis is the presence of atypical antipsychotics. So the typical antipsychotics tend to work against dopamine. The atypicals tend to work with other neurotransmitters, serotonin in particular. So for example, here is a typical antipsychotic. Here's its effect on dopamine. Here's the size of its effect on serotonin. It's more effective on dopamine. That's typical. Atypical doesn't affect dopamine, seen here, as much as serotonin. And yet the atypicals work. In fact, many psychiatrists advocate starting with an atypical antipsychotic. In some sense, they may be more effective for the negative symptoms in particular. So we see a difference in approach. Now, to be fair, some psychologists think this categorization is not a meaningful one, that all of these drugs exist on a spectrum of some sort, so putting them in categories doesn't help. But your book does it, and many sources still categorize them by typical and atypical, and many psychiatrists do as well, so we'll stick with it. So again, neurally, we've already seen some differences between individuals with and without schizophrenia. At the smaller scale, what do we think is happening? Well, in addition to the dopamine hypothesis, there's also the glutamate hypothesis. And drugs such as PCP, what we see here, affect the glutamate system. So glutamate is our most common neurotransmitter. It's an excitatory neurotransmitter. And if we look at an NMDA receptor, we see that it has a binding site for PCP. So PCP, if the drug PCP is taken, PCP is phencyclidine, otherwise known as angel dust. If it binds to the NMDA receptor, it shuts it down. It is a glutamate antagonist. And again, one can exhibit some of the symptoms of schizophrenia, hallucinations, paranoid delusions. And so the question is, because PCP that we see here imitates these effects, is schizophrenia really the result of underactivation of glutamate receptors? So PCP inhibits glutamate in terms of, and with regard to the NMDA receptors. Does schizophrenia do the same thing? Does it involve too little glutamate activity? Unfortunately, you can't just apply glutamate or glutamate-enhancing drugs to the nervous system because glutamate is our most common excitatory neurotransmitter, and glutamate-increasing drugs will cause seizures. So this isn't so much an avenue for treatment as it is a way of understanding what schizophrenia is. And these aren't mutually exclusive, the dopamine and glutamate hypotheses. Both of these may have part, but not all of the story. And treatment, while it again alleviates and tends to alleviate the positive symptoms in particular, treatments are not perfect. There are a number of side effects that come along with the treatment of schizophrenia. There's what's called tardive dyskinesia, where the person will, and this occurs after long usage of, in particular, the typical antipsychotics, that after the person has been on them for a long time, they'll start to have stereotyped facial movements. They'll grimace or stick out their tongue or blink. And this is not the direct result of the drug. In fact, if one has taken these drugs for long enough, one can cut off the supply of the drug, and the person will still exhibit these symptoms. So this is not the effect of schizophrenia, and it's not even the direct effect of the drug. It's the effect of being on the drug for a long time. So this is a more typical outcome for long-term typical antipsychotic use. For the atypicals, because they involve serotonin, and serotonin is involved in appetite regulation, weight gain is a very common symptom or side effect for the atypical antipsychotic. And so there is no perfect treatment. There certainly is no treatment that alleviates all the symptoms, but there's not even a treatment that's free of side effects. And the side effects can be unpleasant. And they're one reason why people will discontinue their antipsychotic medication regimen, even though it's keeping them from exhibiting the symptoms of schizophrenia. Sometimes those side effects are deemed unbearable. The person will stop taking their medication and exhibit the symptoms of schizophrenia again. So here's another video. We're going to see an individual with some of these side effects. We'll see some of the disorganized thinking as well. We'll see some of that tangential thinking in particular. But we'll also note that the person has sort of stereotyped hand movements. And that's one of the treatment's side effects.
Sit down. How are you doing?
Not doing so hot. I think and feel as though people have called me here to electrocute me, judge me, put me in jail, or kill me, electrocute me because of some of the sins I've been in.
Is this a new feeling for you?
The main thing is don't get excited, but the thing is it's not a new feeling, no. I'm scared of people.
It must be very frightening for you, though. Feel like you're about to get killed.
I'm so scared I can tell you that picture's got a headache.
Can you tell me more about that? The picture has a headache?
You want to know?
Yes, I do.
Okay, when a sperm and an egg go together to make a baby, only one sperm goes up in the egg. And when they touch, there's two contact points that touch before the other two. And then it's carried up into the egg. And when they fuse, it's like nuclear fusion, except it's human fusion. There's a mass loss of the proton. One heat abstraction goes up in the electron, spins around, comes back down into the proton to form the mind, and the mind can be reduced to one atom.
Okay, so we saw some of that stereotyped hand movement that is a side effect of antipsychotic treatment. So this person clearly is still exhibiting symptoms of schizophrenia, but also side effects of antipsychotic medication. Okay, so that will do it for our unit on schizophrenia. We defined it. We saw some of the symptoms. We have positive, negative, and cognitive symptoms. And we saw the risk factors. There are genetic risk factors. There are environmental risk factors. And we saw how those combine to produce schizophrenia, particularly if one has a lot of both. We saw how schizophrenia relates to the brain. We saw differences in brain structure, brain development, but also brain activity, particularly differences in the frontal lobe. And then we wrapped up with treatment. So again, there is no cure for schizophrenia. There are medications that can treat it, but they are not perfect. They have side effects. They don't necessarily treat all of the symptoms. And so that is one avenue of heavy research. Schizophrenia is quite common and quite disruptive to one's life. And so we are always working on finding new treatments, finding better medications for schizophrenia. So that will wrap it up for our unit on schizophrenia, and it will also wrap up all the new content for this course. So going back and looking at the course overall, this course is obviously about the behavior and the brain and the relationship between the two. So we learned how the nervous system is organized, the different parts of the brain, the different structures in the brain, also how neurons work, how neurons use chemical and electrical signals. And that sort of was our foundation. And of course we relate that to psychology, to the phenomena that we are all familiar with: memory, attention, emotions, consciousness, even if we haven't given them that much thought before. These are all critical components of our lives, and they all depend on the brain. And so it behooves us to understand the brain as best we can. And as you move out of this course, hopefully you're in a better position to digest the science that comes out from now on. You can relate it back to what you know about the brain. And so when there's a news story about a new research finding or a new discovery that, in terms of a new medicine for a disease, you can understand how those things work, and you can evaluate the science. You can evaluate perhaps the claims that are being made. Are those claims merited by the study that was done, by the results that have been discovered? So moving forward, you can follow progress in biopsychology, brain and behavior, and fields that are related to it: psychology in general, medicine in general. What applies to the brain applies a lot to the body as well. And so hopefully you've expanded your knowledge of biology, human biology, and you can apply it to the brain in particular, but also your own well-being and the well-being of those around you in general. And if there's one lesson to take away from this course, it's that you are your brain. So take good care of it. If the brain is injured or develops a disease, that can affect every component of your personality. It can affect how you make decisions, your capacity to reason and plan for the future. We know from patients like HM, whose brain we see here, that memory is housed in the brain. You can lose components of your memory. Attention, which can be hard to define and is something we take for granted all the time, is still something produced by the brain. And then even at the very small scale, we can see how the brain changes. We can see how psychoactive drugs affect the brain, and how the large-scale function of the brain depends on what it's doing at the very small scale. So hopefully you've enjoyed the course. Hopefully you've learned a lot about the brain, about its relationship to psychology. And again, hopefully you'll be in a good position moving forward to keep on applying the knowledge and the skills that you've gained in this course. So I hope you enjoyed it. I certainly enjoyed teaching it. So what's coming up is, again, no new content. We are done with new content. As always, be sure to take the online quiz for this lecture. But the big thing on the horizon is Exam 3. So Exam 3 is coming up next week. So start preparing for it. You now have all the material that you need to study for Exam 3. And the review lecture is, in fact, already up. So go over this lecture a little bit, and then take a look at the review lecture to see what you should really focus on moving forward. So with that, good luck on the final, and I will see you then.